Good morning, gentlemen. Thank you, Shirish and Nilesh, for inviting me to Pune. Pune is my second home in shoulder surgery. Right. I'm not selling remplissage. We're just going to talk about the person role. As far as the recurrent shoulder dislocation is concerned, this is what you see. You got a patulous inferior capsule because of repeated dislocation and a huge heel sac lesion because of repeated dislocation, and that shows your anterior labral tear. So we have been addressing so far about the Bangkok repair for many years, and this the heel sac lesion got attention only recently. I have done a good number of heel sac remplissage repair in UK, but after coming to India, I've done more of these. Reason being, here the patient come to surgery only after repeated episodes of dislocation ranging from 10 to 20. For the bottom line shows the different type of heel sac lesion we encounter. We all know very well that heel sac lesion a significant contributor for recurrence instability, and the options existing were not good with reliable results. So what is remplissage? In French, it means to fill in. So basically, we put an anchor in the heel sac defect and we repair the posterior capsule and infraspinatus onto it, thereby making the heel sac lesion extra-articular. So these were the technique described with the two anchors with simple sutures and the sutures tied in the subacromial space, or a double pulley technique using two anchors, 4 sutures, and sutures tied in the subacromial space. Does it heal? Pascal Boileau proved very well, healing in all patients with the heel sac coverage over 75% in 75% of patients. So we have evidence for that. Does it restrict motion? This is the false conception saying that remplissage will tighten the shoulder and restrict rotation. It is not. This is the published evidence. There will be some restriction of rotation to the tune of 10 degrees, which is barely noticeable. This is because we are not offering remplissage for acute first-time dislocator. This is only done for a repeated dislocation where there is already capsular laxity and infraspinatus stretching. So thereby it doesn't restrict movement much. So does it improve recurrence rate? Yes, very well. That is the range, around 4% recurrence on average if you add remplissage to these patients along with Bangkok repair. And how does it compare with other procedures? Bangkok repair versus Bangkok remplissage, 0 versus 20%. And with other treatment for heel sac defect is good. And here is a systematic review of 26 studies with 769 patients. Remplissage with Bangkok repair lower recurrence than Bangkok alone. Same way, the other procedure for heel sac have high recurrence rate, complication rate, and poor outcome. So this is how I do, is a viewing from anterosuperior portal. You see the heel sac lesion on its profile. So, and it's important to establish an accessory posterior portal. If you do it from the same posterior portal, you will tend to have the wrong angle. So you had to prepare the heel sac lesion because it's always covered with a layer of fibrous tissue. So you had to make it bleeding because we want the capsule and the infraspinatus area to heal to it, not just stick to it with the anchor suture. And then you choose the correct location of anchor. If the anchor goes closer to the articular surface, it causes tightening. And this is the gray zone patients where they get stiffness. If the anchor goes far lateral, it will not get the effect of your infraspinatus stenosis because it attaches only the insertion of infraspinatus onto the humeral defect. So it should be just 5 to 6 millimeter away from the articular surface. And suture placement, usually piercing type of a device is better. You could either take the suture through the cannula or withdraw the cannula and do it through the subacromial space. The sutures could be tied in the subacromial space blindly by withdrawing the cannula, or yourself you could go in the subacromial space, clear everything and tie the knot. And that shows the reduction and repair. And once you pull the sutures to you and the repair closes, you would see the humeral head getting centered against the glenoid cavity. When the lesion is too big, what I do, I put 2 anchors and then both are double loaded. I tie one after the other. So that is how shows the 2 anchors remplissage, and that's a labral repair in that particular patient. and that is the final result of remplissage. So this is the order of repair. You first do the inferior labral repair, get the IGHL tension first, then place the remplissage anchor and suture in place. Don't tie it. If you tie it, you will have difficult to come back again and complete the Bangkok repair. So you do the Bangkok repair and finally come and tie the remplissage sutures. It's very important, if you do remplissage, you have to mobilize early, and it's my practice to mobilize them from day 2 postoperative with active assisted arm elevation up to 90 degrees. So there is consensus now as of today. There's indication for remplissage is that large engaging hill sac. That is a previous concept. Vivek has beautifully described off-track lesion, but with less than 25% anterior glenoid erosion or bone loss. Second, it is a valuable tool in revision arthroscopic surgery. So Vivek clearly told the one single investigation we do is a CT scan. What I ask is this, a 3D end-face profile of glenoid compared with the opposite shoulder. So you don't need a big measurement, it just gives a visual perception. So this is okay for remplissage. And that is maybe okay if you have a reasonable quality of labrum to repair. And that is not. So this gives a visual perception. Opposite shoulder is always scanned, but only if you ask, they will pull the image information and give you the picture. So let us look at a few cases where it is applied. So it's a 25-year-old man, fall from ladder, 2006, very high number of repeated dislocation, and that shows the heel sac defect, an easy dislocation. And that is the Perot picture. We have done the inferior labral repair and the heel sac remplissage as I described. And on the right side, you see the completed repair. And I checked them at range of movement at 1 year, nearly full range flexion abduction and reasonably good external and internal rotation. I check also at 90-degree abduction because that is much more important for day-to-day life and sport activity. And if you see, there will be around 10-degree difference between the two sides. And I check with MRI scan, and that shows the MRI follow-up showing the filling of a heel sac lesion on the right side. So this is another case where this 22-year-old young student had elsewhere arthroscopic stabilization. It's actually in complete repair of the labrum with one anchor. It doesn't address the problem. So this is at arthroscopy. You would see the labrum is still not repaired, is redundant. And you see the suture there. But when you come back, you will see the remplissage. Automatically, when I take up these patients, I always do remplissage. In recurrent dislocation after some initial attempt at arthroscopic surgery, I don't measure the heel sac lesion, I go for remplissage, because that will protect your anterior repair. So that's the result of labral repair. And then on the right, it shows the heel sac repair. It's the anterior labral repair, and the humeral head is centered over the glenoid. Here, in this situation, the remplissage, I think, protects the anterior labral repair. So that is him at 2 months post-operative doing the external rotation at 90-degree abduction. So this is another case where he had multiple surgeries before. He had some procedure to detach the coracoid and reattach it, and also he had an open screw repair of anterior labrum elsewhere. So that is the story so far. So first dislocation 95, repeated dislocation, recurrent dislocation over 20 times. That is the open approach scar. So I did the CT and I found a very huge heel sac lesion, but interestingly, normal glenoid. There is no glenoid bone loss. You have a screw, but which is quite medial to the labrum attachment. So I decided to do a scope, and I found this. There is a huge heel sac lesion. It's certainly off track. You see the guttering because of repeated dislocation. And you see the anterior labrum is still there. You could release and reattach it. So I have already counseled the patient either to go for arthroscopic or open. So we just continue to do the arthroscopic repair of that labral repair. Before, we just put the remplissage anchor, a double-loaded sutures, and the sutures in place. And that is the anterior labrum after release. Superior labrum was also torn. So this is after repair of both anterior and superior labrum. And this is the final results. Remplissage repair, humeral head centered over the glenoid, and the anterior labral repair. And that is his patient, same patient at range of movement at 1 year and at range of movement at 90-degree abduction. So this is his MRI scan follow-up at 1 year. You could see the anterior labral repair and the location of 3 anchors with intact repair, and the heel sac anchor and filling of heel sac defect. So in conclusion, remplissage is an adjuvant arthroscopic technique. It extends your arthroscopic indication to address patients with recurrent dislocation with a large, engaging or off-track, whatever you call, heel sac lesion, and certainly in revision cases. And in revision cases, it protects the anterior labral repair, I believe. Thank you very much.